great privilege. I would like to welcome Dr. Rutula Sonawane, who is an associate professor in palliative medicine in Bharati Hospital and Research Center, Pune. After obtaining her master's in palliative care from Tata Memorial Hospital, she is currently working there. And she is into something which is essential. Research is what is needed in any field. And she is into research, especially in palliative care medicine, looking into non-oncology and pediatric population, their requirement and how is it going to be useful for them. The main thing for us to know is that we need to understand what exactly is palliative care. Many myths are there which needs to be understood first by the professional team very well, so that it could be taken to the public and overall palliative care could be provided to everyone and utilized by one and all for the welfare. Over to you, Dr. Rutula.
Ma'am, you are muted.
Can you hear me now?
Yes, ma'am.
Yeah. So thank you so much for the kind introduction. We'll head on to our presentation and we'll discuss as things go along.
Ma'am, just give me a moment. We are sharing the same from our end.
No problem. So in the meanwhile, since it's loading, so can anyone just tell me what is their concept about palliative medicine in non-oncology in general? Like, what do you know? What do you want to know, and how things are? Anyone?
I think in non-oncology, we can include conditions like heart failure, chronic kidney disease, COPD, pulmonary fibrosis, interstitial lung disease.
Right, very
or
good.
Maybe basically gangrene, diabetic, end-stage, complications of diabetes, like gangrene.
Right.
If there is like a acute limb.
Right.
Yeah, these are the conditions that are coming to my head.
Right. Anything else particular to all these conditions that, like, how is it different from dealing with maybe an oncology patient, like a cancer patient?
I think
pain may not be a main symptom in this case.
Pain may not be a main symptom. Yes. Anything else?
Old age, mostly in older
Age, yes.
population.
Yes. Imminence of death, immediate pain. Right. Correct. Okay, so let's just move on and see how things go. Next slide, please. Okay, so just to briefly summarize again what palliative medicine is all about. So as we all know, it's an approach that improves the quality of life of both the patients and their families. The patients include both adult patients and children. And these patients are facing any problems that are associated with a life-threatening or life-limiting illness. So basically, we make this possible by early identification, very good and correct assessment of what these symptoms are, and these include everything which is physical, psychological, social, and spiritual. Next slide, please. So have you seen this graph before? So basically what it used to imply was, previously it was thought as that any disease, especially chronic diseases, when they were diagnosed, only the curative treatment or the disease modifying treatment will go on, and at their end of life, or when the treatment are no longer working, they would get a palliative team involved in the care, and which will mostly be around the time when there is patient's death. But now the whole scene has changed as to kind of initiate palliative care and supportive care, as we call it now, to be started almost immediately after the diagnosis of any chronic disease or life limiting illness, and it goes hand in hand with the disease modifying treatment, and it further extends to bereavement care and bereavement support as well. Next slide, please. So as I was saying, this goes hand in hand. So this is the bow tie model where your disease management and palliative care goes hand in hand, where there is symptom management. Pain is specified because, you know, pain is one of the most commonest symptoms, but symptom management and your rehabilitation goes hand in hand with your disease management and disease modifying treatment. Next slide, please. So basically, to just kind of brush up, there are a few competencies that you as a member of a palliative care team should have. So basically, we should be able to describe what is the palliative care approach and how we are going to manage the patient. Then we should be able to address and manage the pain and other symptoms, which which are fatigue, anxiety, depression, anorexia, cachexia, etc., very effectively. And we should be able to take thorough history and come to the root cause of these symptoms, and maybe manage them by doing any, like you can do some investigations, you can do any procedures, or refer such patients to such certain procedures which may help them. Next slide, please. Then we should be able to participate in care of a dying patient and support their family as well. So we should be able to identify what the signs of approaching death are, what are the signs of natural dying process, and how we can support the family, how we can communicate with the patient and the family that the death is nearing, and we might have to prepare for the worst. Next slide. And also we need to, it's important to take care of the body after the death also. So it's still a person. So you cannot be very rough after, like, it's not that, you know,
Dr. Rutula?
formalities, at least if the patient leaves the hospice or the hospital, is very smooth. Can you hear me?
Yes, I think we lost. Not sure if it is from the hub side, but we lost you for a couple of seconds. Now it is okay. Please continue.
Oh, okay. So the next competency is to be able to assess the psychosocial and the spiritual needs. So there are various tools for screening of psychological needs, social needs, and spiritual needs. So we should be aware of the tools which are relevant in our society. So not all the tools which are usually from international countries, like usually from the US or the UK, they might not be pertinent to our scenario, because the level of understanding in their patients and our patients are different, and the concept of spiritual needs or religious needs are very different from theirs. They are, and maybe take not the completing, maybe you can take few points from each of the tools to help you assess for any spiritual or psychosocial needs. And we should be able to fairly manage these symptoms also. But this does not include that if you're not able to, then you won't refer them to their particular doctor or particular department. So if there is a social need which we are not able to provide properly, you will have to refer them to a social worker department, who will be able to do it much better. So we need to kind of have the inputs from all the departments and get them involved as well. then it's important to get a clear idea about what the end of life decisions are for the patient and the family. And this should be based on the bioethical and legal framework of our state or of our country as well. So, but these needs to be addressed, and these needs to be made clear from the get go, and it should be documented as well, so that we might come back to it, kind of reshuffle it or make a few changes as well. But it's important to have that mapped out for everyone. Next slide, please. Then, as I said, communication is very important. So we should be able to communicate very efficiently with the patients, their families, and other caregivers who might be involved in the care. And always remember that all the symptoms, all the sources, all the possible sources of suffering, there are multiple, and it's always multidimensional. You cannot have like just one thing that is causing the suffering. So one thing leads to another thing leads to another, and it becomes like a vicious cycle. So it's always multidimensional. So you always should address it as a multidimensional symptom or a source of suffering, and manage effectively. Can you just hold on for a moment? I'll just shut the door and I'll come back. Just 2 minutes.
Yes, ma'am.
Okay. So as I've said, always a multidimensional source of suffering, and manage it accordingly. Next slide, please. Along with all these competencies, it's necessary to have self-awareness, and to realize when you are burnt out, or when you are in the phase of going down the hill for yourself as well, because you won't be able to give your 100% to the care of your patient if you are not 100% yourself. So it's important to know when you might need a break, or you might need some help yourself. So it's important to have that self-awareness, and have some techniques or some extracurricular activities for your own self-care. So it may be exercise, it may be yoga, it might be meditation, it might be just reading, listening to music, or playing music, anything which you enjoy, but it's important to have that as well. Next slide, please. So as we all know, the 4 roads to death. Graph A shows a sudden death, which might be due to like a fatal accident or a sudden cardiac arrest, which leads to like a sudden event, where it's usually what most of us prefer, that I go in a second, where none of us realize what is happening, but it might not be for everyone. Graph B is for a terminal illness, where there is a disease modifying treatment that goes on, but after that a gradual decline in the health, which leads to death. Graph C is for organ failures. So it's basically, as you can see, there are troughs in the middle. So basically there is waxing and waning of health, but it never comes back to its original baseline. So as you can see, if you go for the functioning line, where it started from, it's always been lower than that when it has kind of deteriorated, the patient has deteriorated. So what happens here is that after every admission, the patient gets better, like he's better than what was the worst thing when he had deteriorated, but never back to his formal good health, and it eventually leads to death. Graph D is your old age frailty, where the function has been declining as you age along, and then which leads to death. Next slide, please. So as we discussed before, so in non-oncology, it's usually your chronic system failures, your neurodegenerative diseases, rheumatological diseases. Advanced cancer is one of the life-threatening illness, but does not has a completely different understanding and more openness to accepting palliative care along their process. And it's important to note that patients who have been in the ICU for a prolonged period of time and have multiple organ failures or not responding to whatever treatment is going on are also candidates for palliative care referral and palliative management. So these patients also need to be looked after. Next slide, please. Next slide. So we'll just briefly go over what are the potential barriers that we face while we are going, kind of treating non-oncology patients. So can you just one more click? Yeah. So can anyone just unmute or maybe type in the chat? What do you think are the barriers for palliative medicines from a physician's perspective? Anyone?
Physician try to cure the disease, not focus on the palliative care.
Right, exactly.
Can you hear me? Am I audible?
Yeah.
So from a physician's perspective, the question, why is it difficult to let go? So like we had discussed previously also, we as physicians or doctors are taught how to treat.
Right.
So we somewhere are not able to draw a line to understand, okay, this is where it is enough. How much is enough?
Right, right.
So the inability to draw that line also causes us to not understand when is the right time to let go.
Right. Anything else? Clinical outcome, yes. Okay, next slide, please. As you correctly said, it's always cure, right? You do not want to, you do not want them not to get better and not go home as they had come in, as they were previous to the hospital visit. So it's always wanting to cure the patient and make them better. Next, and if they are not able to cure the patient, it is considered as a personal failure as well. And also if they refer it to a palliative medicine department, it is as though they are giving up on the patient. So it is like a whole mixture of things which are not true. It's kind of and it kind of shows how much lack of knowledge that they have about palliative medicine. So it's a mixture of things. Sometimes might not be true, sometimes lead to a feeling of guilt as though they could have done something more for the patient, but they couldn't. So it becomes like a turmoil for them as well. Next slide, please. What do you think it is from the caregiver's perspective? Why do you feel that the caregivers are not willing to go for palliative care?
Lack of knowledge. Again, they feel that
Right.
The doctor is giving up, the patient's gonna
Yeah.
die, so they
Right.
don't want, they're not ready to face that. They're
Right.
not they're probably in denial, or they don't want to accept.
Yes. Anything else?
It puts more of a burden or more of a responsibility on the caregiver rather than on the doctor. When there's some active treatment going on, it's like, okay, it's a doctor's responsibility.
Right.
But when it comes to palliative care, most of this thing is on the caregiver, the responsibility and practical issues are on the caregiver.
Right. Yes, refusing to accept what is going on. Yes. Next, please, can you come till the end of the slide? So as we said, the disease trajectory in non-oncology is kind of very varied. And it's not as though they're seeing the patient decline, or like they're not seeing a very evident decline in their health. It's very subtle. And as I said, especially in organ failures, after every admission, the patient gets better. So, and it's kind of very difficult to pinpoint when that deterioration is going to lead to death. So you don't know if it is the second one or is the third time, and they've had multiple hospital admissions, and multiple times the patient has come out of the ICU even and gotten better. And as of course, even we would want everything to be done for our loved ones. So we would not want to stop giving the treatment, or it's as though we as their family are also giving up on what they are going through, and they're maybe leading to more suffering as well. There is always a guilt when them as caregivers decide not to go for further treatment. So it's like, oh, I'm not giving them any treatment, like, why? Like, am I doing the right thing? Am I killing them on my own? A lot of thoughts come in. This is especially seen when the children or the relatives who are the main caretakers are living abroad, and they are in India with another, a caretaker or an attendant who is actually looking after them. And as always in our society, it's like, what will people say that we are not giving them treatment, we are not shifting them to the ICU, we are not giving them, we are not putting them on ventilator, or we're not giving them any medications, and they're just letting them die. So it's society's perspective as well, because there is a general lack of awareness about palliative medicine. Next slide, please. So coming to the diseases, again, so I am not going into the details of all the disease and disease trajectories. I am just kind of enumerating what are the possible diseases that are there in all the systems, and what are the possible symptoms, and maybe, just kind of briefly discuss how to manage those symptoms, and will go across. Well, I'm not going into all the details about it. So in the central nervous system, there are mainly patients with dementia, Parkinson's disease, your traumatic brain injuries. Stroke patients will be referred to palliative medicine, or can be referred to palliative medicine. Next slide, please. And the potential symptoms. So there can be seizures, there can be paresis or plasias, differing on where it is affecting. There can be dystonias, there can be hypertonia or hypotonia, can be dysphasias and aphasias, all sorts of things. Next slide, please. So just the management in brief. So rehabilitative measures come across the disease, potential diseases that are there. So not only in central nervous system, but in respiratory symptoms, in cardiovascular symptoms, in your hepatobiliary, renal, everywhere, rehabilitation, if possible, should be given to the patient, even when they are palliative medicine. So because they help a lot. For your dystonias and for your hypertonia, your muscle relaxants or baclofen can be used wherever necessary. It will help with the pain as well as your spasms and muscle contractures to a certain level, not completely. Analgesics, opioids, non-opioids, wherever and how they are required, should be used. Anti-epileptics, again, if the patient is having seizures, not getting controlled with whatever regimen of anti-epileptics, you need to step it up or add another one as and when required. What is your thought about nasogastric or peg feed in such patients? Do you think it should be given, or do you think that it is not necessary? And
so coming from geriatric background, so I deal with the geriatric population. So in there, when we have patients with PD having difficulty in swallowing, where there is always a clinical question of how to continue the nutrition.
yes,
So there is this, when they are stepping from the hospital, they have been given this idea of either continuing with an NG tube versus PEG. in which what I have observed is a lot of families coming from a background where they want to do their best end up agreeing to physicians wanting to go ahead with PEG, although it's an invasive procedure. But also at another extent, I have seen in the geriatric population, a lot of families also understand that at this age, they do not want to, have any invasive procedure and rather continue nasogastric tube itself.
Okay. Okay. If suppose the patient had an acute old age, again, acute stroke, and he's having dysphasias, and let's say the prognosis is very grave, and you don't expect the patient to survive for more than maybe a week, and week is extending it to the maximum. So would you still want to go for a PEG NG feed? PEG though is out of question. You're not going to put them through any invasive thing. But would you want to go for an NG feed in this case?
Given it's not imminent or if it's like towards a week, maybe to start with, what I have observed in my setup technically is they start with an NG feed and they see how they are, tolerating it.
Okay.
In case we're looking at something imminent, then we take the next step.
Yeah. So as you know, you correctly said, it's always been a very contradictory or a debate-inducing topic, whether to go for feed, be it NG feed or a PEG feed, or not to go for a any type of invasive therapies. So again, it differs from case to case. As she correctly said, if it's an that the patient won't survive and that death is imminent, you would not go for any invasive procedures. Even NG tube insertion is also kind of invasive, so you would not go for it if you think or if you know that the death is imminent. But if there is some sort of survival benefit, that that the patient would benefit from NG feed or a PEG feed, and that the survival is maybe more than a month, then you would go for NG feed, because the other option then becomes parenteral nutrition, which is not always economically advisable as well. So you need to weigh in the pros and cons of all the options that are available, and then give suggestions accordingly. Speech aids are very useful, especially the ones nowadays. They're all electronic, where kind of laser pointing, they kind of point out towards all the alphabets and everything, but it's again technologically very advanced and may not be available in all the centers, or may not be financially feasible as well. So another option is to if the patient is able to kind of blink or make any movement, so you ask him to make one such movement for a negative answer and two such movements for a positive answer. So you ask them very leading questions so that they can either blink or kind of move their lips or anything that they can possibly do. Next slide, please. Coming to cardiovascular diseases, so it's basically heart failures. You have your congenital heart diseases also, which again leads to your heart failure. That might be Eisenmenger syndrome as well. Next slide, please. So main symptoms is your breathlessness and chest pain, which might be perceived as heaviness as well. There is palpitations, which they say as your heart is racing and can lead them to think that it is anxiety. There is edema, cough can be present, fatigue, and sleep disturbances. Next slide, please. So as I said, rehabilitative measures wherever possible, go for it. And it will be helpful to a certain degree, and might even kind of help you reduce the pill burden in these patients. So wherever possible, rehabilitative measures. Opioids, again, so especially morphine in this case will benefit with the pain and for breathlessness as well. So it should not be thought of that it will lead to further respiratory depression and death. It should, if given in a monitored and safe environment, they are wonderful drugs, and can help a patient a lot. Diuretics wherever required, like there's a lot of pedal edema and peripheral edema, so diuretics will obviously help reducing the preload to the heart as well, so they might be beneficial in that sense as well. Beta blockers, again, plus and minus. It will help with reducing the sensation of the heart racing, basically with palpitations and feeling of anxiety. But again, it needs to be given in a monitored sense. Like if it is going to negatively affect your functioning, then they should not be given. Oxygen support wherever required, because many times the patients will feel better with even a low dose of oxygen. So wherever required, oxygen support should be given. Next slide, please. Your respiratory diseases. So it's basically end-stage COPD and ILD. You have your core pulmonary and your pulmonary embolism. Next slide, please. So the symptom profile is kind of similar to your cardiovascular. So breathlessness takes a front line. You have your weight loss, fatigue, you might have delirium, palpitation again is present, and might have headache. Next slide, please. So again, more or less same as that of cardiovascular symptoms. Opioids here will basically mainly help with the breathlessness. Diuretics, again, certain studies have even shown that nebulization with furosemide has helped with breathlessness, but to what degree is questionable and has not worked very well when we have tried it in our setup. But it has been shown to prove to have some sort of effectiveness. And acetylcysteine works in nebulized form, helps to a certain degree with breathlessness. But this is along with all your other nebulizations like your steroids and your anticholinergics, etc. Oxygen support, again, wherever required. If the patient is having delirium, then antipsychotics have to be used. More commonly used is your haloperidol, which is, you can start off with a once a day dosing and can increase it as and when required. And steroids, again, wherever you feel that a steroid will help, especially in patients with COPD and ILD, then they should be given, and the dose should be monitored in and tapered down once the patient has settled down. Next slide, please. So hepatobiliary is basically your end-stage liver diseases. So it is basically liver failure, which is most commonly due to your liver cirrhosis or your hepatocellular carcinoma, but here we are dealing with just non-oncology, so it's cirrhosis leading to failure. Next slide, please. So the common symptoms are your nausea, vomiting, fatigue, weight loss, and all the signs of liver failure. Next slide, please. So can anyone tell me what would be your choice for antiemetics here and why? Anyone? So basically, you're going to be using steroid might help, but not to a certain, not to that extent, because it's you're dealing with the non-oncology here. Ondansetron will work wonders. Yes. Can you tell me why? Lactulose is the preferred laxative of choice, but might not help with the nausea and the vomiting. Ondansetron, yes. Can you tell me why?
Less hepatotoxic.
Yeah, and
safe and renal.
safe and renal, yes, but okay, just coming back to the what is the reason for your nausea and your vomiting in this scenario? In a patient with, let's say, liver cirrhosis and liver failure as well. So what is the reason why there is nausea and vomiting?
Trigger of the chemo CTZ
Right,
because of accumulation of toxins,
right,
because your liver is not able to metabolize properly.
right. Yeah, exactly. So basically you want a medicine that will act centrally, which will basically cross the blood-brain barrier. That is what you need. So steroid will work to a certain level. Ondansetron, yes, because it will go centrally. Any other choices?
Domperidone.
Metoclopramide better than domperidone because domperidone does not cross the blood-brain barrier. Yes, the cause is CTG stimulation, bilirubin elevation.
Olanzapine.
Olanzapine will work. Anything else? Haloperidol.
Haloperidol.
Yes. Dopamine. So all these will basically any drug which will act centrally. So you can give anyone according to your preferences, anything that acts centrally. So for pruritus, like one of the signs of liver cell failure is your pruritus. So for that, we'll give sertraline. So there is, kind of like a step 1, step 2, and step 3 for management of pruritus because of cholestasis or because of your hepatobiliary system. So in step 1, it is generally sertraline. You start off with sertraline. If it is not working, then the second drug of choice in step 1 is your rifampicin. But again, you'll have to kind of see if you can actually give rifampicin in this patient. Then in step 2 is your danazol. Again, you will not go for it. And I don't know if it may or may not work. I've not given it personally to a lot of patients, or I have not given it to any patient. So I've usually used sertraline and it works wonders, and like immediate action even in 1 day. So it works wonders. And the third step is your naltrexone, which will help with pruritus. And as we already discussed, the laxative of choice is lactulose. Anyone wants to go in the mechanism of action of this? Why lactulose? Something to do with the ammonia that is getting, it kind of washes it off, and so basically reduces the ammonia level. So that's one. Okay, and the supportive measures. So again, you have to signs of liver failure. So you have your ascites, so that might need draining. You might have bleeding from the portovenous anastomotic sites, so you might need to kind of manage those as well. So any of the other signs which may occur, so you might have to treat them and give supportive measures as and when needed. Next slide, please. Coming to the renal diseases, so it's usually the end stage kidney diseases, most of the time because of hypertension, diabetes, and glomerulonephritis. Next slide, please. Symptoms: nausea, vomiting again, decreased appetite, fatigue, urine output decreases over the time, signs of fluid overload, that is your edema, chest pain, breathlessness, headache, etc. Pruritus, again, you have your muscle twitches and your muscle cramps, and sleep disturbances. So anyone wants to tell me, again, it will be a centrally acting antiemetic that we'll use here. But next slide, please. But what is the mechanism here? Like, why centrally acting? There it was bilirubin, here it is
Uremia.
Yes, correct. So it's basically uremic symptoms. So, and what are the antipruritic agents of choice? Sertraline, not so much here. And
Ondansetron and metoclopramide.
yes. No, I'm talking about antipruritic agents. But you're correct in
Antipruritic,
saying that the antiemetics are ondansetron and metoclopramide.
Antiemetic. Yeah, antiemetics. Okay.
Yes. So here you can use your phototherapies. UVB will be useful in uremic pruritus. Your step 2 is your gabapentinoid. So your pregabalin or gabapentin will help in these patients. And the third line is your sertraline and naltrexone. So sertraline comes down the line here. Any preferred laxative here? GABA, yes. Any preferred laxative? You can use any. You can use lactulose or your Primapen Plus.
Lactulose, yes.
And again, as I said, supportive measures wherever required, you'll have to. Next slide, please. So I wanted to kind of mention the breathing, thinking, and functioning model. I'm not sure if it has already been covered in previous lectures or that if it is going to be covered in the next ones. But it's important to know because breathlessness occurs in almost all the system involvements and it is multifactorial and the management also is a multidimensional one. So as you can see, one thing leads to another. So it's like a vicious cycle that is occurring here. And this diagram kind of makes it easier for you to manage it as well. So because there is increased work of breathing, then you can give a relaxation and mindfulness techniques to reduce the anxiety that is occurring and will kind of help with the breathlessness. Then again with your thinking and anxiety, panic attacks that you have, they can give you advices on how to manage the distraction therapies are also there. You have your kind of reconditioning measures also for the functioning part of it, and you have your handheld fans or breathing techniques to help with all the three major aspects of breathlessness, and thus will kind of help you manage the breathlessness better. Next slide, please. Just a brief about end of life care. Next slide, please. So the Indian Society of Critical Care Medicine had come up with this confusing flowchart about end of life care in palliative medicine. Can you just give me a minute? Sorry. So as I was saying, this is very confusing. So simplified version is next slide, please. So basically to simplify it, most of the patients will either be from your emergency departments or inpatients or ICU admissions, and you have your relatives and patient coming to your OPD as well. So if there is a prognostic uncertainty and the primary physician who is the main physician for the patient and has assessed and he also feels that there is some prognostic uncertainty, then there should be consensus about the said uncertainty among all the treating physicians, and then there should be kind of an honest and early discussion about the said prognosis with the patient and the relative, and we should kind of establish what the goals of care are. And after that, if the patient is, let's say, in the ICU or is on some form of life-sustaining treatment, whether to withhold it or whether to withdraw it if according to the wishes of the family and the patient, and to give an effective comfort care or supportive care to the patient and the family till the death of the patient. And it's important to document everything at every step, and revisit it and change it according to what is happening with the patient. So this is a very brief and generalized end of life care pathway sort of a thing. Again, you can modify this according to your according to your setup and according to your hospital, but more or less will go along this pathway. Next slide, please. So we have like a very, very long road ahead of us, especially when it comes to non-oncology, because like even the physicians are not aware of what palliative medicine is and how it can help their patients. So the patients are like a different game altogether. So it's a huge, long road ahead. And let's hope to reach the destination as soon as possible so that we can provide excellent care for the patient. Thank you so much. Next slide, please. Thank you. Any questions or points for discussion?
Thank you very much, Dr. Rutula. See, essentially, you got the point exactly, well conveyed. Many physicians are not aware, not that, because this has not been part of it. We all know only to cure. See, in this program itself, we were all told, and I have been always telling that Being Mortal is a book which should be read by everyone. Because exactly the 4 types of death, what you mentioned, 4, it is there. All these are there in the first 100 pages of that book. So it is to be read by one and all. So first thing, to concise what you've said, you've done an excellent presentation. Main thing, awareness and teaching. Awareness, education and teaching of the common people. Many of my friends now, whenever I say, they say, oh, we all would want to know. So people are interested to know. So that has to be taken up. And then reassure the family first. Don't be scared. You can do it. Any family, if they are taught, they will be the best carers.
Right.
So that is the second point. And then once you reassure them and then train and teach them, there are so many home care. For last 4 years or so, I have been into this and I teach them all home techniques.
Oh,
no, like there are everything. See, for mouthwash, all of you do. I am not doing rocket science. As I used to work in Cancer Institute, mouthwash, they need not buy. We used to tell how they can prepare with 1 liter of water. That's all there in the palliative care thing. So if once you teach them, so that is something. Dressing techniques, we used to teach them. No need of an autoclave. With the pressure cooker, you can. So there are so many things which can be taught to the family. Once you reassure and teach them, and it is not a difficult thing at all. Once that is given, the best, and many studies, I have done some audits and things which have shown end of life, 8 to 9 out of 10 patients want to die at home. That's the global statistics. I'm not telling anything, and these are all global figures. So when something like that could be achieved, only thing, educating, training, reassuring, and attaining that.
Exactly.
So that is the best way, and so which you have conveyed, and either people could raise, unmute and ask, or type in the chat, or we can go along with the case presentation and come back for discussion. The total choice is yours. I will leave it to the participants, whatever they would want to do. Any burning questions, unmute and ask, or we can go with the case presentation and come back together. Okay, well, Sripriya, you can go with the case, I think.
Dr. Malika?
Yeah, the case presentation. The patient is a female patient, 88 years old, and she has dementia. The presenting complaints she has are of memory loss, and she also has a change in the thought process, which has led to a change in her behavior also. She has poor time sense and also decrease in personal hygiene and grooming, and also a decrease in food intake. The history of illness, she has had a slow memory loss over a number of years, but these changes got accelerated when her husband, to whom she had been married for 61 years, passed away just before the lockdown. So both these situations made her isolated, and this aggravated that. In addition to this, her thought process and behavior changed. She hides things, including food items. She leaves the tap on or the gas stove on, and she doesn't realize that something different. She wakes and sleeps at odd times, eats only certain foods, and her level of personal hygiene has deteriorated, and she resists any help or advice in this matter. On examination, she is healthy, physically active, her BP is 110/70. All systems examinations are normal. The treatment and significant investigation, all her lab investigations are normal. Hemoglobin is 11.2 grams. Total count is 6,800. Urine is normal. Serum electrolytes also normal. She was a mild diabetic for the last 10 years on oral metformin. But she got COVID recently, and after that her food intake increased and her sugars also went very low, so metformin was discontinued. Psychosocial aspect, she lives with her daughter and daughter's family. She feels isolated as her husband passed away at around the same time as COVID restrictions were in place. And she also got positive. She was COVID positive, and so she couldn't attend church or any of the other related activities in the church that she actively participated in earlier. Her son passed away some years back. All her siblings are no more, who earlier lived close by, and this has increased her sense of isolation. Medications, she's only on vitamins and eye drops for her glaucoma. The main concern is her forgetfulness and altered thought process, which makes it impossible for her to be left unsupervised or left alone. And also persuading her to eat healthy food and bathe and groom herself. This is a challenge to her daughter, who's the main caregiver. The summary is she's an elderly person with dementia who needs constant supervision and a lot of care with patients. The discussion points, what sort of care would be best for her? What would be ideal? Daycare center or a person trained in looking after persons with dementia to look after her at home? Or is there any other thing that can be done? And how to persuade her, how to deal with her in getting her to eat well and take care of personal grooming as she resists all this. Thank you.
Thank you, Dr. Malika. Exactly what is needed is what excellent case you have brought forward, because this is something which is very common. Like all of us have elders at home. So, and dementia is something which is very, very much present, maybe which was not well known before. So this is something which is there in every household. So worth discussing, and maybe we'll go ahead with the responses one by one to your questions itself. That would give and main thing, one thing what I would like to say is hopelessness, helplessness, and loneliness is what has brought her or pushed her to this state. Anyone going through frailty and aging can go through that until and unless, even though they have been well organized or whatever it is, there's no, the variable factors for dementia, the independent and dependent variables are so vast and variable. So this is quite a common thing to happen. And so we'll ask for what would people want to say, what sort of care would be best for her, like either type or, okay, someone has written something in the chat. In this case, home care would be the ideal one, as daughter is the only carer. Yes.
I would like to pitch in for this.
Yes,
So,
please.
Looking at the-
Geriatrician's input will be very good.
So, thank you, ma'am. So, from the history that the doctor shared with us, see what we have also observed at our center. So, we work at a rehabilitative center for geriatric, where we have both palliative and rehab patients coming in. So, what I have observed from the history that I've got from a lot of families these days is, most of the elders whose children are in this youth, or they are in their mid-30s or 40s, the families are working, and they have grown-up children who are also involved in some other thing. And what happens with dementia again is it can have behavioral changes or no behavioral changes. So in case there is a behavioral change with dementia people, having somebody who's trained to take care of elders with dementia would be an apt setup. But given that, like Dr. Radha also mentioned, helplessness, hopelessness, and loneliness, social interaction becomes a very important part. So wherein an activity of meeting others and speaking to them, socially getting involved, helps them at a very larger scale also. So given, maybe somebody who's taking care of her in case she has no behavioral issues, but also ensuring that she has some sort of social interaction outside the house will also be very helpful for her. Given that if the family is not able to spend time with her at home, and definitely also for family, they also have burnout points sometimes, because constantly these elders do not know what they are doing. They might be having issues with soiling and they need so much of care. The families also go into a burnout. So at such situation, considering a daycare center which can involve all of these activities would also be a very good option given the history that we are looking at.
I would also like to, I completely agree with Dr. Ruhi. Another thing I would like to add is that the caregivers of such patients have a lot of burnout in them. Like, just continuously taking care of another child. It's almost like taking care of another child. And also a very stubborn child at that, like, not doing certain things, not agreeing to most of the things, and being very irritable and kind of sometimes aggressive as well. So there's a lot of burnout in not only the main caretaker, but across the family. Like, even like, I'm sure even her husband would be kind of not fed up per se, but kind of irritated because they don't have the freedom to do what they need to do or they want to do. So sometimes it's even beneficial if they could kind of have like a respite care center where they can get like the patient admitted for a couple of days or maybe a week or so, where the family and the rest of the members kind of get a rest and recharge themselves to take care of the patient again. And as you said, a trained caretaker, care attendant is very beneficial, especially in dementia patients, because you do not want to leave them unsupervised, and God forbid if they go outside the house and get lost somewhere, then that'll be another huge scenario. So having a trained attendant is always better.
One more thing I just wanted to add that I missed out in my last discussion was So what we understood, what I understood in my last 2 to 3 years of being, treating or being with the population, elderly population is, so geriatrics is almost like pediatrics 2.0. So that's what we are, we try to propagate, and most importantly, educate the families on this, of how to adapt to this.
Some form of counseling, both for the family and the patient.
Exactly.
Because many times, like as everyone has mentioned, burnout is a big issue. Respite will help. Some amount of counseling for them separately and together might help in their relationship also. Because everyone is looking about themselves. Yes, truly understood, because burnout is known, very well known, and respite will help. But bit of counseling for both, to make sure that this hopelessness, helplessness is all what you think. So this same thing, this breathing, thinking what was shown, that is a vicious cycle happening in everything. So by dealing with little bit of counseling, that vicious cycle can be broken. Rather than going deep down, it could be helpful for the patient, carer, and everyone to benefit. And that is why of late, the WHO definition, everything about palliative care has transformed so much to put patient and caregiver equal importance. So counseling in that part might be helpful. I know it might be difficult, maybe difficult to get a psychologist or someone, at least some form of general counseling, listening, communication, listening, even if you listen to both and make some arrangement, multimodal management, that will help in the first phase. So little bit of concern relieved, then they themselves might find a way out. They might say, okay, we will accommodate with her, something like that could happen.
Right.
So that is something I would just like to add on.
Absolutely true. How to persuade her to eat well and take care of personal grooming? I am not sure whether we can. I'm like, if she's too stubborn and too aggressive regarding this, then I don't think she will listen to you. But I don't know if, kind of, because I've not had, patients with dementia, and I've not kind of managed them as well as you guys might have. But maybe making it into an activity instead of forcing her to eat, like maybe sit together and eat, or maybe how kind of how we do with toddlers, then just make it into an activity, whatever they like, just keep it in front of them, make it into a play sort of a thing, and just how much ever they eat, and don't force them to eat one chapati or two chapatis or this much of rice and that much of dal. Just how much ever they eat, just that is fair enough for them. And maybe after a certain amount of time, let's say after an hour or so, just keep something else in front of them so they can just have 2 more bites of that, and just go along that way. And just even personal grooming, like just make it into an activity where they kind of feel that they'll enjoy doing it, rather than making it as though you have to do it, or this will happen and that will happen. So it's kind of, I'm just guessing this should help. Personally, not had a chance to do that.
No, as you said, we will do gastrointestinal in our next couple of sessions. This is one of the common things which is taught for even palliative care. See, normal standard pattern of 3 meals a day doesn't work in this. Frequent small meals every hour or 2 hours, because as I have had personal experience also looking after elders. So what works even for children, as you got a very good pediatric, geriatric are like 2 extremes.
Yes.
But they have some similarities also. We all know that, we have seen physiology and learn. So like that, this frequent small meals is something which is recommended, because they won't be able to eat as much. And and especially with dementia, they will totally forget. So they would have thought, if you ask them, oh no, I ate, they'll say they wouldn't have had anything at all, but they will say by words that they ate something and all. So like that, no, the dementia per se itself, looking after people with dementia, like in dementia, they can be pleasantly confused or aggressively confused. So that also is there. So it all matters how they are. So we'll have to deal with it. Our geriatrician in our group can throw some light to us.
In terms of eating well and taking care of personal grooming again, see, like we understand, it is the condition which is causing them to not being able to function in their daily routine, which is again why one of the reasons why we have a caretaker or a designated person to assist them to do this. From what we have observed, it is very difficult to teach them something new, but it is always possible for us to ensure that we try to delay the deterioration, wherein we are doing the cognitive training and retraining, for example, activities with their basic, daily routine activities, like, maybe trying to do some cognitive, like some crosswords, some puzzles, even so much as coloring, and also sometimes trying to give them activities to do with their grasp so that they are able to hold things, or maybe to even consider holding a glass to take it forward to begin with. So it all starts with how we are training child, training them on to how to eat on a plate, or how to, and similarly how we are taking the measures for a child, how we are ensuring there is somebody feeding them, or somebody ensuring how they are drinking water, all how we have to more adapt the things around them is what mostly is done with the patients with dementia.
Thank you. Basically, tailor making things to their need.
Yes.
Elderly care itself is like that. And more so when dementia sets in, one golden statement is they can't learn something new. That's why it's a short-term memory loss. So that itself will become a challenge, and then they'll be upset and they may not do what they were doing. So it is a challenge, and then having a carer is something will be essential, and their financial situation is what you have to have in mind if you're able to accommodate, and then look at how it could be accommodated. I think that would be a way.
It is quite difficult in India, at least in some parts of India, very difficult to find trained carers for old age or dementia patients. So that is a big issue.
Truly said. Exactly. But finding some trained personnel is a challenge. Finding a personnel itself is a challenge. And then finding a trained personnel is really a challenge. I totally accept. And maybe Dr. Rutula, any input you could add on to that, please?
No, I completely agree. It's a huge challenge to there are not many centers who look after the elderly and patients with dementia. We need to have more of them. We need to have more home care services as well for these patients. And if we could, even providing trained attendants for such patients, or rather training nurses or social workers or psychologists in caring for such patients would go a long way in helping the overall care needed for such patients. So.
Also, I think Dr. Radha mentioned, training the caregivers also is another important thing that we can do. To at least train them how to maintain hygiene, or feeding, how to give them proper feeds, and like you mentioned, involving and engaging them in small activities at home itself. And in this case, I think isolation was a problem. So daycare center would definitely be beneficial for this patient, because in a daycare center, you can have, say, music therapy activities with other patients similar to such a patient,
kind of
or
like
music therapy
support system. Yes,
exactly.
like support therapy that we say, support teams and support.
Yeah, like multidisciplinary, or you can have
Yeah.
a MSW come in, or a psychologist come in, evaluate, something like that, that can be organized.
Right.
Yeah.
Even one day in a week. See, it may, because we have to look at the financial situation also.
Yeah, absolutely.
See, that daughter may be the only person. So so even one day in a week, if something like that is started, that will give a break for them. And then the person also might enjoy. And then something, breaking the ice is what many times does wonders. So something better than nothing. If something like that is done, at least one day in a week, and then looking at the option of anything else, availability stuff, and training someone in there. See, sometimes grandchild could be there, we can tell them, and then grandchild and the grandmother can have a better interaction. So we have to look into all pros and cons and availabilities and move forward in that. And I'm just seeing in the chat, what is the dance therapy, music therapy, art. Yes, there are so many, pet therapy, everything is there. That is why I say, no, if we start thinking and start to utilize what is available, that will be more beneficial rather than looking for something which is difficult to obtain. Maybe a trained person may be difficult to get, but what can I do with what resources that I have will be a better way forward. See, good that we had nice, like we had like a geriatrician who could throw more light to us. So, because that's how, the main thing, the interactive session is that, no, many brains can help and only multiply. So that is how, end of the day, and that we all get the benefit out of it is the primary thing to be taken. And see, it will keep on improving. See, palliative care is not only in India, the whole world is in the same state. Everywhere it is there. And one important thing, what I would like to mention is, see, through the discussion, it came up, many tools are there. We always say, tailor make it to the needs of your setup. Any quality of life question, everything, whatever you take, you translate it, you make it to the regional cultural demands. Everything is there. That's like a framework. Then you build on it to what you need and tailor make it to your support. Only then the patient also will reveal the truth.
Yes, that is
something what is there. That's why there is everything available. Just as a small guide, I would like to say, because I have done that when I was in Chennai. Pick up any questionnaire, okay? Do a forward translation. See, this is all I'm trying to share so that all of you will benefit out of it. And I have done that, okay? Do a forward translation and a backward translation, okay? Take any questionnaire. So when you do a forward translation and a backward translation, and the backward translation should result in the same, the answer should be similar to the original questionnaire. Then that is all sorted. And then do according to what you want. So I have done one quality of life questionnaire because in Chennai, I did a Tamil forward translation, then Tamil to English. I've done all that. I'm not telling or talking anything what has not been done, okay? So like that, you have to pick up any questionnaire and do that and then utilize it as a tool. So you have plenty of stuff for depression, for distress, for psychology, for mood. You have so many scores and everything available, but utilize it and make it to your needs. And then see how best you can get something out of it. So like that, that is what you have to do. You have to give importance to regional, cultural importance, spiritual. And so all that you do accordingly and benefit out of it.
We are already doing it in Chennai, ma'am. I think you know Rutula. Rutula
yes.
Senior Care. Yeah, I'm the Chief Medical Officer.
Rutula.
Rutula Senior Care.
Okay.
Yeah, we have 150 people here. now.
Okay.
We have a training section. We have a trainer.
Where is that?
and,
Where exactly in Chennai?
Chennai 1 in Pallavaram, on Leelankarai, Arumbakkam,
Okay.
and
All places.
Perumpudi. Now we have opened in Bangalore. I come to Bangalore for the opening inaugural functions here. Yeah.
Okay.
What we do is we have a trainer, and this trainer trains them when all the caretakers come, and the induction class will be given. And it is a continuous process. We keep on training them, because the concept is very difficult to make them understand. Some of them will stay with them, some of them will run away. Then, so what happens?
So you're
we keep on
training
training
the
them.
carers or your
Caretaker for dementia, for
caregivers.
Parkinson, caregivers. And these caregivers have been trained in such a way that they should not miss any meal at all, because the dementia people forget to eat. Some people
Yes. I've had one of my very close friends' dad. 2 years he had, and then we have looked after him. I've known him. He was a very eminent person. So, but what I'm telling is, he was in a state where he will not eat at all, but he will always say he's had full meal.
That is what our training program is, a continuous process. We keep on training the caretakers.
Good. See, that's what I told. I'm getting the answer straight away. If we keep on doing, we are going to succeed. So let us all be blessed by God to move forward in the right way.
It's blessed. We are blessed, so blessed that we have so much of senior people here. Doing service, giving them a care itself is blessed.
So that's what, it's all part and parcel of it's just like it's a give back thing, I say. That's what we have all obtained so much of knowledge and things. Let us help the whole world. The palliative care is improving, and it is a challenging field, and awareness is what has to be increased. And it is,
we started palliative care recently, and so they want the doctor to be certified to use morphine and other things and all.
Yes,
so
yes,
that's the
only
reason
then,
I have joined it.
Exactly. Yes, you need that, and that's a good thing.
Yes. Even though we know what to do it, but we have to be certified to do.
No, everything has to be, you have to follow the norms and rules, and following that is the best way forward. So, and nothing wrong. We all as we say, like you do year 1 to year 10 and you get your year 10 exam to say that you've passed, something like that only. So why should we deny this? It can be done, and can be done properly.
Yes. And it's pleasure attending classes, ma'am. Such a nice classes, nice lectures.
Amazing.
Every day learning it.
That's what. So not only us knowing, let us tell to as many as we can, and let everyone get benefit out of it. That is the main aim.
Exactly. Thank you, ma'am.
Anything else anybody would want to say? If not, how are things, Sri Priya?
Yes, ma'am, we are well on time.
So if everyone is happy and satisfied with what topic we've had today, I will take the opportunity to thank Dr. Rutula in total. We all had an informative, enthralling session, and we had a lovely discussion too. See, appropriate case we had, which that is what we all need to know. Something which is very common, very well known to one and all. And how can I manage that?
Yes.
So that's what we did today. So thank you one and all. And thank you once again, Dr. Rutula, for giving us enough information that was needed.
Thank you so much, ma'am.
Thank you, Dr. Rutula, for joining us. We know that your day has not ended at having a busy schedule, and still you found out time for joining us. Thank you so much for that. And thank you every participant for making this interaction as lively as possible. So with that positive note, this is Sri Priya along with Dr. Rutula and Dr. Ratha Venkatesan signing off from the Tips Eco Hub. See you in the next session with the continuation of communication session with Dr. Biju Raghavan. Until then, everyone, take care, be safe, be happy. Bye-bye.
Bye. Thank you.
Thank you.
Thank you.